Dear ESTS members and webinar attendees, my name is Lieven de Pieper, your moderator for today. This webinar is the second one of the third season of the ESTS educational webinars, and the subject today is an expert talk on the role of neoadjuvant and adjuvant treatments for thymomas. I'm very proud to introduce you to our expert for today, Professor Frank Detterbeck. Professor Detterbeck is Professor of Surgery and Chief of Thoracic Surgery at Yale University. He's also the Associate Director of the Yale Cancer Center, and his major focus is on thoracic oncology. He has a very special interest in mediastinal pathology, as you can see in several chapters of our ESTS textbook, and a very active membership of the International Thymic Malignancy Interest Group, ITMIC. Therefore, I think Professor Detterbeck is our perfect expert for today. Professor Detterbeck, please.
Well, thank you. Thank you for the invitation. And, I'm happy to join in this webinar. I hope that, I can present some things, but I also hope that we can have some discussion afterwards. So I hear one person saying they can't hear anything.
Well, for me, the sound is perfect, so I don't know if some other people having this problem. I don't see it right now in the chat box, but if there's a problem, please let us know. I hear you very loud and clear.
Okay. Well, so I would start with I prepared a few questions about some theoretical cases. I thought we would just sort of sample what people think. So maybe we start with those cases.
Okay. So if you go to your right sidebar and you look to polls, there you can find the first case. Maybe you can give some comment on the case, Professor Detterbeck.
So my right sidebar.
Yeah, you have the questions, and then you switch to polls.
So, questions. Okay, polls. Yeah. Now I see it. Yes. Sorry.
Okay, but people are already starting to vote.
Oh, okay. So, this is a 3 centimeter B3 thymoma, completely resected. The patient is fit. The question is adjuvant radiotherapy. So that's really the issue here.
Do we already publish the other questions as well, or?
No, let's wait and see what the answer to this is.
Okay.
So I will leave it to you to stop the voting when it's appropriate.
We are.
And of course,
170 people connected right now, and let's say about 70 were voting. So we at least have 100 people who didn't vote yet. So please.
Well, it's a very sensitive topic for us about, how long to continue to count the votes.
Is it?
Well, with the U.S. election, there was a lot of a lot of debate about that. Might have to take you to court. If you don't do it right.
There's no judge here today. Okay, but I think it's quite clear. 1/4 of the audience voted for yes, radiotherapy, adjuvant, and the other 75% said no. Any comment?
Okay, so let's go on to the second case then.
Okay. There it comes.
Okay, so this is a thymoma. This is a question about how you would handle it. So it's a 6 centimeter thymoma that is abutting the superior vena cava in an ominate vein. Looks like it's involving the right upper lobe. Again, patient is fit. And the question is, how would you treat this patient? Direct to surgery, preoperative chemo, chemo RT, or no surgery and just chemo RT?
This is interesting. It started with a high number of surgical resection, then it went to pre-op chemo, and now it's going to surgery again. So please keep on voting. Okay, I think there's not a lot changing anymore. We have about 30% of the audience voting for option 1, surgical resection, possible adjuvant radiotherapy. More than half, 55%, is voting for option B, preoperative chemotherapy followed by resection and possible adjuvant radiotherapy. And a minority is voting for option C, and only 2% is voting for definitive chemoradiation. So we have an audience of 30.
Okay. Well, let's go to the third case then.
The third one is coming.
Okay, so this is incidentally detected thymoma involving the phrenic nerve on the left side, involving the left upper lobe, and there is a pleural implant. So the question again, how do you approach this? Definitive chemoradiotherapy, preoperative chemoradiotherapy, and then resection either with a local resection of the thymoma and the pleural implant, or extrapleural pneumonectomy.
Seems to be more difficult because less people are voting. Take your time.
Well, of course, these are the challenging questions, I think, that we face with this disease. What do we do?
Okay, no more people are voting. We have almost 100 votes now. And not a lot is changing anymore. So 60% of the audience is choosing option B, preoperative chemotherapy, followed by resection of the thymoma and the pleural implant with adjuvant radiotherapy. And then almost, so 22% is following option D, being preoperative chemotherapy, resection of the thymoma and the pleural implant, intraoperative pleural chemotherapy and adjuvant radiotherapy. So this is between the intraoperative chemotherapy or not. And then a minority is choosing for other options. But most of them are saying pre-op chemotherapy, resection, with or without intraoperative chemotherapy, followed by radiotherapy.
Okay, well, I think that sets the stage. So let me start the presentation here, and then we can have a discussion afterwards. So.
Okay.
Let's see, here we go. Okay, can you see my screen?
Perfect.
Okay, so I'm going to go through advances in treatment of thymoma and thymocarcinoma, particularly adjuvant, neoadjuvant therapies. I have no conflicts to disclose other than that I have been interested in this disease for several decades. I'll say a little bit about stage classification because I think it is important when we talk about it. So the current stage classification, I'll give you a few highlights from the data that was used to develop it. So there was no difference whether there was a capsule or penetration of the capsule. So that was part of the Masaoka and most of the other older stage classifications, but we found no difference in recurrence or survival, and so that's not part of the current stage classification. We had looked carefully at size. We used this fancy log rank statistic to find the optimal cut point, 10 centimeters, but we could find no difference in either outcomes and no difference in the ability to do a complete resection either. So size is not part of it. So these are just the survival curves for the different T classifications. And these are the T classifications. So T1 is invading the mediastinal fat or just encapsulated, invading all the way to the mediastinal pleura. T2 is involving the pericardium. T3 is involving lung, the brachiocephalic vein, the superior vena cava, phrenic nerve. T4 is involving other structures like intrapericardial structures. There are 2 node regions that are defined, and pleural implants or distant metastases. And you can see survival and recurrence curves that fit that. And this is how it's grouped together. So stage 1 is T1. Stage 2 is basically T2 and 0. Stage 3A is T3. Stage 3B is T4. Stage 4A is N1 nodes or M1A, which is pleural or pericardial implants. And 4B is N2 nodes or distant metastases. So that's just to get us on the same page. So now I think when you are approaching patients, you know, one of the issues is that the agreement between clinical and pathologic stage is not very good. I think we have work to do. So this was data from the ISLAC-ITMIC database, but you can see that, I wonder if I can get my mouse working. You know, this is ideally if the clinical and the pathologic stage were agreeing, everything should fall in this diagonal line, but you see that there are, you know, plenty of circles that fall off the line where the pathologic stage does not match the clinical stage. A couple of points, I think it's important to do a CT with IV contrast that really allows you to define things much better. Limited abutment of the tumor to pericardium, the lung, the innominate vein rarely correlates with invasion. So we have to be very careful to call that invasion. What's more important is to look for an irregular border, you know, of the vessel or the pericardium, a lobulated contour at the lung interface, encasing of 50% of the vessel circumference. Those are things to pay attention to, and limited abutment is really not something to pay much attention to. So obviously, if the hemidiaphragm is elevated, you know the phrenic nerve is involved, but if it's not elevated, it doesn't necessarily tell you. I think a thin slice CT is important to look for pleural or diaphragmatic nodules. They are sometimes hard to see, but lung parenchymal nodules I don't pay much attention to, and enlarged nodes I also don't pay much attention to.
Can I just interrupt you? The bar that is there, can you click on hide? Then they can see your total slide.
I'm sorry?
Instead of stop sharing, you click on hide, and then this bar will disappear.
Okay. Okay, thank you. Okay, so then let's go on to treatment. That's really the topic here. So I'm going to start with stage 1 and 2. So this is involvement of the mediastinal fat, or involving the pericardia. And I think a couple of questions come up, open versus minimally invasive. So this was a study that looked at the ITMIG database, and we looked at we looked at patients that were resected either with an open or a minimally invasive approach, and we did not really see, there was a bit of a difference here in the R0 resection rates, but there were many differences between the cohorts, so we did a multivariate regression, and we came up with propensity match patients, and in those patients there was no difference in the R0 resection rate, whether it was open or minimally invasive. We did not have enough follow-up time to really assess recurrence, in the study. Another question that comes up is total versus partial thymectomy. Again, an ITMIG database study, and there are some differences in the patients, but if you look here at the outcomes, the R0 resection rate, not different, recurrence rate not statistically different, 10-year overall survival not different. New onset myasthenia was actually a little bit more common in the total resection rate, but there was a difference in median follow-up. So we also did a propensity matched analysis here and did not see a difference in recurrence or overall survival for total versus partial thymectomy. This came as a surprise to me, but I think this is the data that we have. Now, I would caution people by, these are all partial thymectomy, but still with a complete resection, an R0 resection. So it doesn't mean that you can just take out and debulk. That's a different question. So let's move on to thymomas that are invading thoracic structures. So a 3A or a 3B. So 3A, for example, invading the lung, or invading the superior vena cava, the innominate vein, and 3B, of course, invading deeper structures.
Mm-hmm.
So one of the questions is the role of adjuvant radiotherapy. And there are quite a number of meta-analyses, and I put this one up there, but I really put it up there because I think we have to be cautious about looking at meta-analyses of non-randomized studies. It's one thing to do a meta-analysis of several randomized studies where you are assured that for treatment A and treatment B, you've done randomization, so confounders should be at least theoretically accounted for by the randomization. When you are doing a meta-analysis of non-randomized studies, all of the confounders that are buried in these non-randomized studies, they don't get removed by meta-analysis. In fact, they get obscured by the meta-analysis. So let me focus on some of these confounders. So here's a SEER study, was published in 2012, and fair number of patients, and they looked at the SEER regional stage or localized stage, and looked at cause-specific survival. And you can see the red curve is the port curve that's higher. And so this study concluded that adjuvant radiotherapy should be given. But I want to draw your attention here. Look at the early part of the curve. And so you have, the problem with these studies, whenever you're comparing two treatments to one treatment, you're being selected twice. You're being selected because you're good enough to get that second treatment. And the difference that you see in this study is all in that early part of the curve. And if you take that out, I move these curves up to take it out, all of a sudden, the surgery arm looks better than the port arm. So this is a matter of selecting healthier patients, not a matter of the treatment being better. And so one way to get around this is do a landmark analysis where you say only those that have survived 3 months or something like that can be included in your study. But this is a common confounder with adjuvant treatment studies where those patients that were too sick after the first treatment to get the adjuvant therapy account for the difference in outcomes. So we can look at this in multiple different ways. These are large database studies of postoperative RT, and you can look here. There are cases that had thymoma. Some looked at an outcome of overall survival. Some looked at recurrence-free or disease-free survival. Some included thymic carcinoma, either purely or all. And the green are studies where it favored port, red is no different. So if you look in the Masaoka stage 1 and 2A studies, no difference, pretty clear. If you look in the 2B and 3 studies, it's not really that clear. There are some that suggested a difference, but many that suggested no difference. R0 doesn't suggest any difference. R1, perhaps a little bit more of a signal that we should do this. Another way to look at it is to say, what are the factors that influence prognosis? And green, again, are the factors that did. And so in these studies here, you can see that stage, pretty clearly has a lot of green. Stage was important. Age is important, especially for overall survival. Again, highlighting that many of these thymoma patients are not dying of thymoma, they're dying of unrelated illnesses. And was postoperative RT important prognostically? Mixed outcomes, not clear that this was some signal that it is, but others that it's not. And one of the problems is that all of these studies are really either clearly confounded or probably confounded. They didn't have information about R0, R1. They didn't do a landmark analysis. I showed you that earlier. They had very few factors involved. So I think that it is very difficult for us to look at these meta-analyses or these multivariate analyses and to really be sure what to do. So that's the data we have. Now, we live in the real world. We see patients. We have to make decisions. So what do? I think there are a couple of conclusions that I feel very comfortable with. I think that for a stage 1 thymoma that is completely resected, R0 resection, I think there is no benefit to radiotherapy. I think that is pretty clear. I think in some earlier studies, there was a suggestion of some downside. I think that with modern radiotherapy techniques, I'm also very comfortable that radiotherapy is safe. So those are things that I think are pretty clear, but that, of course, doesn't help us that much. So when I look at the data and try to come up with, what do I think it shows me, I would say that if it's an incomplete resection, R1, R2 resection, I would certainly give adjuvant radiotherapy. In fact, I would consider adjuvant chemo as well. If it's an R0 resection, stage 3, but it was invading some lung, I stapled off some of the lung, I have a nice negative margin, I'm not concerned about something, I think there is a little bit of it to adjuvant radiotherapy, and I don't do it in those situations. But if the margins are close, I had to dissect the phrenic nerve away from the tumor that was very close to the phrenic nerve. Those sorts of situations, even if it's R0, I would give adjuvant radiotherapy. So that's my my recommendation, how I read the data that we have, even though it is, less than completely clear. So what about the pre-op chemotherapy question or chemoradiotherapy question? So these are a number of phase 2 studies that have been done looking at this question. You can see here that some of them included stage 4 patients. Some of them included thymocarcinoma, preoperative chemo, not that many studies that had preoperative radiotherapy, but most of these studies used postoperative radiotherapy. And if we just look at the bottom, so the response rate was pretty good, 67%. Average R0 resection rate, again, this is stage 3, 68%. Pathologic complete response rate, actually about 11%. And if we look at overall survival, 5 years, 10 years, it's pretty good. So I think that's the data that we have. Now, if you compare that to studies of stage 3 that did surgery with or without adjuvant radiotherapy, and most of these were adjuvant radiotherapy, the data is not as good. So the R0 resection rate was lower. The 5 and 10-year survival rates were reported as lower. Now, this is a comparison across studies from one study to another study, where I think we have to worry a lot that there are other confounding factors. I don't think we really know for sure, but there is at least a suggestion that there may be some benefit.
Mm-hmm.
So my recommendation is, if it is easily resectable, I would go straight to surgery. But if it's a thymoma where I'm a little bit concerned, I might end up with an incomplete resection, a positive margin. That's where I would give preoperative chemo, whether it's preoperative chemo or chemoradiotherapy. I don't think we have any clear data on that. My personal preference is to err more on the side of preoperative chemo, and then at the time of resection, I can pinpoint where the radiotherapy is going to have the biggest impact and not radiate the whole, field. So that's my preference. So what about thymomas that have pleural implants? So these are a number of studies that have addressed this topic. You can see that some of them included a lot of patients that got extrapleural pneumonectomy. Preoperative chemo was not done as frequently as I would have thought. Adjuvant treatment was much more frequent in these studies. Operative mortality, pretty acceptable. About 58% R0, R1 resections. I'm not sure that with pleural implants you can really talk about R0 resections. And 5 and 10-year survival rates are actually pretty acceptable for what is fairly advanced disease. Now, these are thymoma patients. About 50% of them recurred. Mm-hmm. Now, we can also look at the data where patients got some intrapleural chemotherapy. Here, heated chemotherapy, different types of chemotherapy. And if you compare, you have at least some suggestion that maybe there's some benefit in terms of long-term survival. On the other hand, there was also a difference in the R0, R1 resection rate. So that's not something that you would expect the intrapleural therapy to have accomplished. So I think that we have to say probably there's a difference in the selection of the patients, or a difference in how the surgery was done, that may be accounting for the survival benefit, and it may not be the intrapleural therapy. So I think we really don't know. There's confounding going on here, and it's hard to disentangle that, and I think we really don't know. What are prognostic factors? This was a nice study from Japan. Lots of things were not prognostically significant. The things that were significant were the resection rate and the number of lesions. I'll just show you quickly here. 1 to 10 pleural implants, actually quite good 10-year survival. Still reasonable if it was more, but certainly better for fewer implants. R0 to 1 resection, certainly better than R2 resection. So I think those are the things to focus on. I'll say a few words about recurrence. So a number of studies that have looked at recurrence. So you can see that the 5 and 10-year survival, this is after the recurrence, is really quite good with surgical treatment. On the other hand, most of these were local only recurrences. We can see that the interval between the primary treatment and the treatment of the recurrence was about 4.5 years. About a little over 50% went on to surgery. These were primarily local recurrences with fairly good outcomes after treatment of the recurrence. Compared to non-surgical treatment of recurrences, it's not good, although it's still a 10-year survival of 30%. So this puts that data into a graphic form. You can see that the 5 and 10-year survival rates are higher with surgical resection of recurrence. On the other hand, I think this is a confounded comparison because those patients that underwent surgical resection had more localized recurrences than those that got definitive chemoradiotherapy. So I think we don't really know for sure, but if recurrence is resectable, I think that surgery is certainly reasonable. Mm-hmm. So this is my final conclusion slide here. Take-home messages, I think. First of all, imaging is a bit hard to interpret, but we need to be careful to not exclude patients from surgery just because there's tumor abutting the superior vena cava or something of that nature. I think it is better to explore and to find out. On the other hand, I also think that people need to try to achieve a complete resection, and so you shouldn't take a patient to the operating room where you say there might be SVC involvement, but if there is, I am not able to deal with that. I'm not prepared to deal with that. I think that you should go and you should say, if I find SVC involvement, I will take the SVC and I will repair it. So you shouldn't get into something that is over your head. I think you need to be careful about that. I think complete resection is important. Debulking does not really have much benefit. I didn't show you that data. I think minimally invasive approaches become quite common, but it still needs to be a complete resection, an R0 resection. The same is true for a partial thymectomy in patients that do not have myasthenia, but R0 resection is still, very important, and we shouldn't deviate from that. Postoperative RT, I would give it if you have a positive margin or if you have a close margin, but if it's a completely resected thymoma with good negative margins, I don't personally give it. I know that there's still sort of an holdover from the teaching from 50 years ago to always give it, but I tend not to. I do think that preoperative chemo has a role, but primarily if it looks like resection might be challenging. And I would be aggressive about stage 4A or recurrence if they are resectable. I think that we do have reasonable outcomes from that. And finally, I'll put in a plug for ITMIG, the International Thymic Malignancies Interest Group. I think it's definitely helping to advance the field, but the ESTS Thymic group is also really contributing, I think, in major ways. So if you want to contribute to this disease, there certainly are avenues for people to do that. Okay, so I will stop here Now, how do I stop sharing? Here we go. Stop sharing.
Okay, perfect. Thank you very much for this very nice overview. I think some things are very clear or made very clear, but we have a lot of interesting questions in the meanwhile. I don't know if you want to address these questions or we go back to the polls first. It's up to you.
No, I think we can just start going through some of the questions. So
okay, maybe we start on with one of the first questions. If we go down a little bit, the impact of myasthenia gravis in thymoma on adjuvant treatment.
well, I would certainly do a complete thymectomy. I would do an extended thymectomy as well as remove the thymoma in a patient with myasthenia. I think that's not one to do a partial thymectomy.
Maybe we're not looking at the same question. You're looking from.
Oh, I'm looking at the last one.
It's also okay. It's also okay. But I was looking to the question of let's see, of Kader Hussein 13 minutes ago. The impact of myasthenia gravis in thymoma on adjuvant treatment. I don't know if there's a relationship between the adjuvant treatment and myasthenia gravis afterwards. Do you look specifically to this myasthenia gravis if you give adjuvant treatment, or doesn't count in your?
Well, I would say it counts a little bit, but not a lot. I think that with good management of myasthenia, I don't think that we have too many exacerbations of myasthenia in the early postoperative period. So I think that patients are usually in good shape where adjuvant treatment is not impacted in a negative way by the myasthenia.
Okay.
I actually just patient from 2 weeks ago where it was stage 3 thymoma and I had to skeletonize the phrenic nerve. I certainly try to preserve the phrenic nerve whenever possible if the diaphragm is still working. And especially in patients with myasthenia, I try to preserve it. So this is a patient that ended up with a negative margin. I do not think it was probably 7 or 8 millimeters away from the phrenic nerve, but this is a patient where I'm advocating that they get postoperative radiation because I think that if they have a recurrence, it's likely to be adjacent to that phrenic nerve, and I would rather prevent that by giving radiotherapy fairly focused in that area. So I often meet with the radiation oncologists to review their treatment plan and to be able to direct them to where I think the radiation is going to make the biggest difference.
Okay, so you really sit together with the radiation oncologist to plan the radiotherapy afterwards.
Yes.
Okay.
Another useful thing is to mark with some clips areas that you are concerned about. That way it's easy to communicate with a radiation oncologist. Just say, make sure that you cover the area that has, I use big clips for markers and small clips if I'm clipping vessels, so I can direct them to the big clips and say, make sure you include that in the field.
Okay, that's also a very practical thing to keep in mind. Then we have 2 questions from Dick van der Amlong. What about the postoperative radiotherapy in cases of R0, but so with clear margins, but in 1 disease or in 2 disease when you have invaded lymph nodes?
Well, I would say I think this is a data-free zone, so I don't have any data to draw on, but I would give adjuvant radiotherapy if there were some nodes involved. Okay,
in this specific node regions then?
Yes.
Okay. And the second question he had was, what about post-op radiotherapy? Again, in an R0 case, but not thymoma, but a thymic carcinoma.
I certainly would be more inclined to give radiotherapy with thymocarcinoma. Certainly we know the prognosis is not as good. We have some indications actually that thymocarcinomas may respond more to radiotherapy. So it would influence me. But if I had a small thymocarcinoma that easily completely resected, I still would not.
Okay. Clear answer. The next question is the effect of neoadjuvant or adjuvant therapy with somatostatin analogs in neuroendocrine thymic carcinomas. Again, very special or specific question. So neuroendocrine thymic carcinomas, do you use any somatostatin analogs?
I would say usually not. Usually we go with chemotherapy regimens, but I think we don't know. I think you can make an argument for it, but I think the data is not very clear. And I guess I leave this question to the medical oncologists.
Okay. Okay, and then of course a very important question: what to do with the follow-up of a thymoma? What do you recommend?
Well, I follow them forever.
Okay.
I think that the recurrences do occur late at times. So we did an analysis quite a while ago, but if stage 1 thymomas, have a rate of recurrence, but it's about 10 years later. The median time to recurrence for a stage 1 is about 10 years later. Whereas for this is Masaoka stage 2 or 3, the median time to recurrence is actually on the order of 3 years or so. So I do follow even stage 1 thymomas even after a decade, but I'm generally only getting a CT scan every 2 or 3 years. After the first few years, I get frequent scans, but after 5 years, depending on what the original pathology was, I tend to get scans every 2 years.
Okay. Okay, but even after 10 years, you keep on follow.
I keep following them.
Okay.
I don't know if it's right or wrong, but I do.
Okay. Then, would you do a frozen section to ensure your R0 margin?
That's a good question. So thymoma in particular, it's less true for thymocarcinoma, but it is often difficult for the pathologist to make a clear call. So I think that frozen section can be useful. I certainly send out frozen sections, but I don't view the frozen section as the definitive answer. Because it often isn't. I think it's hard for the pathologist to really make a call. And so I have learned to, rely quite a bit also on my impression. So I factor in what the pathologist thinks, but I don't use that to discount my impression. If my impression is, I'm quite comfortable this is safe, and the pathologist as well, I'm not too sure, I would go with, I would continue to use my impression as well. I think sometimes people rely too much on the pathologist, and your impression at the time as an experienced surgeon, I think still has to count.
Okay. Okay, next question was, in a non-myasthenia gravis thymoma, would you recommend just a thymectomy without total thymectomy? But this you were already answering, I think.
Yes. Yes.
Yeah. Then the role of intraoperative hyperthermic chemotherapy, indications, and any experience you have. So we have seen a few in your presentation, but there you mentioned that the R0 section was higher, so there was probably a sort of bias on the surgical side, not really the intraoperative chemotherapy. Or any other comments?
I think we don't know. So we have not used intraoperative chemotherapy. So I have been doing betadine, using betadine to irrigate the pleural space. It's simple. That's what I've been using. That also has some data for it, but it's certainly a lot easier to do than heated chemotherapy intraoperatively.
Okay. Next question is about the phrenic nerve. You already talked about that, about when to save it, whenever possible, of course, especially with respect to myasthenia patients. But I think you are on the same page there.
Yes. So I'm looking at this routine mediastinal lymphadenectomy. Well, ITMIG came up with some recommendations, close to 10 years ago, I think. It was just a consensus recommendation, but it's still what I follow. So I think for a stage 1 or stage 2 thymoma, we would try to, include sort of anterior mediastinal nodes and N1 nodes. We would try to include those and send send those off, but I would not go looking for N2 nodes that weren't already suspicious. If there's a suspicious node on a scan, I would go for that, but if not, I wouldn't. On the other hand, I think if you have a stage 3 thymoma that is say invading the nominate vein, invading the superior vena cava, then I would take out the paratracheal nodes, the deep nodes. I would try to do a node dissection.
Okay. Okay, that's also very clear. So the role of frozen section, we already talked about that. Also, when pleurectomy is performed, but I think it's the same there. It's probably if your experience as a surgeon, that also is important.
Yes,
role for frozen section when pleurectomy is performed.
Again, I think that it can be helpful. I mean, it is another piece of data that you have to try to make decisions about what you do. But I have come to rely much more on my impression at the time, and I don't use frozen section that often.
Mm-hmm. Okay, and then you talked about the difference between the WHO classification and the Masaoka classification. The impact of the WHO classification in the decision of adjuvant radiotherapy or neoadjuvant treatments.
It doesn't really influence me very much. There's a correlation between the WHO and the stage. WHO type A are most often stage 1, and B3 is much more commonly a stage 3. So there certainly is a correlation there, but in the studies that have kind of separated that, I'm not so convinced that it has a lot of independent additional prognostic value, and so I tend to not use it very much. It does influence my thinking a little bit if I'm on the fence and about whether adjuvant radiotherapy is worthwhile, and it's a B3 thymoma. I'm sure that would tip me on the side of the fence of saying, let's give adjuvant radiotherapy, but it's not a strong indicator. I don't say, well, by definition, B3 is going to get adjuvant radiation. I don't do that.
Okay. Okay. Would you perform an extrapleural pneumonectomy for stage 4 thymoma in order to have an R0 resection?
Well, I think it is debatable if you have pleural implants from mesothelioma, from thymomas, what sort of an R0 resection are you really achieving? It certainly is a small margin. So I think that's somewhat debatable. I think that, I certainly, and I think most people have moved away from extrapleural pneumonectomy and done more of a local resection of the pleura and area of pleural implants. But, I would still, and have continued to do extrapleural pneumonectomies at times. But it's really when there is extensive involvement, including extensive involvement into the lung parenchyma of the diaphragm, where I am really not, I don't think I'm going to be able to achieve, I would say, an R0/R1 resection without an extrapleural pneumonectomy.
Okay, so in selected cases you would still do this, huh?
Yes.
Okay. The lymph node dissection, we talked about that. Does the seronegative myasthenia gravis influence the surgical decision?
Well, I think, yeah. So in terms of a complete thymectomy, I would say if there is evidence of myasthenia and a thymoma, then when doing that thymectomy, that thymoma resection, I would do an extended thymectomy. If you're going to be there, I think you might as well, do a definitive myasthenia operation either way.
Next question. For tumors invading the phrenic nerve, any surgical options intraoperatively to prevent diaphragmatic paralysis? Or you would observe and plicate the diaphragm later on?
Well, so if the phrenic nerve is still working, and it is able to be, the tumor is just, up against it, abutting the phrenic nerve, then I would try to dissect directly along the nerve. I just isolate the nerve by itself and try to preserve it. I certainly try to do that in patients with myasthenia. Now, if the tumor is growing around the phrenic nerve, where I would have to cut the tumor open in order to dissect the phrenic nerve out, in those cases, I would generally sacrifice the nerve. If I have sacrificed the nerve, I do plicate the diaphragm. You're there. I think it's generally doesn't take that much longer to do. I think that it probably is of a little bit of benefit. I'm told by the radiation oncologist that they find it beneficial in terms of their fields. So I would typically do that. Now, it brings up another point, though, that I've been thinking about. There is some data for restoring function of the phrenic nerve by, bridging across a gap with, sural nerve or something of that nature. And there are plenty of times where you are taking a piece of the phrenic nerve, but in fact, you could probably bring those ends together at the time directly. And I wonder if we shouldn't adopt that as a standard approach, that we resect a portion of the phrenic nerve, but whenever possible, that we try to anastomose the ends of the phrenic nerve. I haven't done that, but I think that we probably should be doing that.
Okay. And how should we do that? Because I think that there will be some...
Well, I think I don't think there's anything magical about it. I think you have to have, I don't know that you really need a microscope as opposed to just, loops that give you more detail, but, as someone who also was trained in cardiac surgery and do, coronary anastomoses and so forth, I think that, I would be comfortable doing it. On the other hand, you can also bring in plastic surgeons or other people that do this. I think it depends on your comfort level and sort of other people at your institution, but I think that you have to see it clearly enough that you can use some very fine, 8-0 suture or something like that in order to bring it together. But, that's what's done when you take a sural nerve and you put in a, bridging piece of sural nerve, and there's a reasonable number of those patients that actually regain function of their diaphragm. So, we probably should be doing this.
It's at least worth trying, of course. Yeah. Any concerns about pleural dissemination due to VATS approach?
So that's a good question. I do not. So let me answer this way. So I think that it is important to do an oncologic resection. So I try not to disrupt the thymoma. If I'm disrupting the thymoma, whether it's VATS, whether it's open, robotic, whatever, I think I'm not doing a good job. And so if I can do a good cancer operation by a minimally invasive approach, so my standard approach really for myasthenia has been a subxiphoid approach. And I have no problem resecting many thymomas through a subxiphoid approach, including if there's some invasion of the lung or invasion of the pericardium. But I would have a very low threshold if I think that I am starting to handle this tumor in a way where I might disrupt it, or I might not achieve the same margin, then I think you should convert to an open approach. And I think that the, sternotomy is really quite well tolerated by patients. They don't have that much pain compared to, say, bilateral VATS approaches. So I don't think you really are gaining that much by avoiding the sternotomy. I do minimally invasive. That is my standard whenever possible, but I have a low threshold to converting to open.
Okay. Another interesting question about adjuvant or neoadjuvant therapy is immunotherapy. What do you think will be the role for immunotherapy in treatment of thymoma?
Well, I think a big distinction is thymocarcinoma versus thymoma. Thymocarcinoma, there definitely has been benefit to immune therapy. I think that it's still relatively early. I don't think we have defined exactly who's going to respond and how well and when to fit it in and so forth. For thymoma, it's been a few cases. I think that it is risky. I think that we probably need to stay away from that at this point as much as possible.
Okay. The very specific question from René Petersen. What do you recommend for pleural recurrence after initial 3-modal therapy, so chemotherapy, then a thymectomy and pleurectomy for a thymoma stage 4A? So there's pleural recurrence after pleurectomy already?
I would take it out. I would reoperate and I would do a local resection of those pleural recurrences. It can be somewhat difficult, but, I'm actually surprised, you would think that sometimes, so I guess this is a patient that has had a pleurectomy, so they're going to have no space. But if you've done more of a local resection the first time where you took out several pleural implants, then when you go back, a lot of times there's still a pleural space to work with just some local adhesions. But I would be fairly aggressive about trying to reoperate on patients if I thought I could do a complete resection of that area.
Okay. Then this question comes back. Is there a role for hemithymectomy and thymoma? So we need an R0 resection, and in case of myasthenia, I think then the total thymectomy will be better. Are there any concerns?
So, question about PET.
Yeah.
I don't.
PET-CT for a thymoma.
Yes. I don't have a good answer for that. I don't really use it myself. I don't think that it is useful to define, say, small pleural implants or something of that nature. I see plenty of patients that have gotten a PET scan, but it's such a soft call. There are patients that have thymic carcinomas and the PET is not that hot. There are patients that have thymomas and the PET is hot, and it doesn't really influence me that much. I'm struggling to really understand what the role should be. Now, I'll say one other thing. I think that MRI can often show you pleural implants better than a CT scan. So I have a tendency to use MRI more than PET.
Fusion-weighted MRI. Okay. Let's have a look. Any other questions? Would you recommend adjuvant chemotherapy for a stage 4 R1 resection? I think you already mentioned that in your talk. Chemo and also radiotherapy.
Yes, I would.
Do you resect lung metastasis for thymic cancer?
Yes, I would, but again, a lot of we see plenty of CT scans where there's some little 3 or 4 millimeter thing in a lung, even when we're looking at patients with lung cancer. The data in thymoma actually is that most of those are actually benign. So I think we have to be careful about that. But if somebody had a growing lung nodule that I'm sure is a thymoma, I would resect it.
Okay. Okay. So the stitches were on the nerve. You said 80.
Saber for recurrences, I think that's useful. Definitely would consider that.
But your first step would be resection.
Typically, yes.
Okay. And then for pleural recurrence, again, it's always the pleural recurrence, of course. With a few macroscopic implants, would you perform an extensive pleurectomy or just partial resection? I think for the recurrences, you would stay for the resection, the local resection. No.
I would still do a partial resection. I don't really see the benefit of taking out the pleura that looks normal now. I said I've been using this, heated betadine is what I've been using. Whether it really helps or not, I don't know, but I put more value in that, I guess, as opposed to just taking out the pleura.
Okay, very good. I think we're about 1 hour, and Olivia Lauk asked us to wrap up a little bit the questions or the answers of the polls, if you can comment on that a little bit. But I think it's already quite clear after this presentation, but maybe we go back to this just to wrap up a little bit. The first case was the 3.5 centimeter B3 thymoma, R0, any adjuvant radiotherapy or not?
I would not.
As the majority of the audience?
I think the data for that is actually quite clear.
Okay, and then the second case was the 6 centimeter thymoma, but abutting the superior vena cava and the innominate vein. with right upper lobe invasion and pericardial involvement. So very extensive resection would that be? And then the question was, what do we do there? Most of the, or just more than half of the audience was saying pre-op chemo, then resection and possible adjuvant radiotherapy. Would that also be your option?
Yes, I think I would probably go straight to surgery. You know, abutting structures doesn't really bother me that much. And I often think of the Garrett-Walsh staging system for thymomas. So he defines, you know, 4 stages for thymomas.
Okay.
There's CS, SF, CBC, and WWIT. So CS is chip shot. It's a golfing term. SF is straightforward. CBC could be challenging. And then WWIT is what was I thinking?
That would be a great final slide, actually.
So I think that, you know, if it looks like it's going to be fairly straightforward, okay, fine, a little bit of an ominous vein involvement, you know, no problem. I will take care of that. You know, I would not do preoperative therapy. In a CBC case, could be challenging. That's when I would do preoperative chemo.
Okay. And then the third case was even more extended with an elevated left hemidiaphragm. So then it involved the phrenic nerve, also pericardium, left upper lobe. And the question was there, yeah, okay, what to do? Most of the audience said pre-op chemotherapy resection and ophthalmoma and the pleural implant, followed by radiotherapy. And then there was a discussion with another 20% of the audience on intraoperative chemotherapy.
So I would go with preoperative chemo. I would try to target the radiation more focally afterwards. And as I said, you know, intraoperative pleural therapy, I think the data is unclear. I've been using betadine because it's simple and easy to do, whereas chemo, I think, brings up a lot of other questions and issues, and I don't know that the data is very strong one way or the other.
Okay. Thank you very much.
Okay.
Today was a great webinar. We had over 200 live attendees. I think it's one of the most popular webinars we ever had in ESTS. So thank you very much. Also to the audience for the many interactions. I hope to see you again in December for our pro-con debate on the treatment of squamous cell carcinoma in esophageal cancer. And I don't know if you have anything to add, Dr. Detterbeck.
No, just, you know, it's been a pleasure, and I look forward to the days when we can meet in person again.
Okay, let's hope that that will be for 2021. Okay, thanks again, everyone, and stay safe.
Okay.